So this presentation is on pediatric respiratory alterations. Unfortunately, children die more of pediatric respiratory complications than they do cardiac, where adults are usually the opposite. Therefore, this presentation is longer than any of the others we're going to do. It's probably one of the most important, and probably it is always secondary to another problem, or another problem is secondary to it. Your textbook is wonderful. Please read it. There are some things in your textbook that we're not going to discuss. And there are things in this presentation that aren't in your textbook. So I went a little bit slower with those. You need to know everything that's in this presentation. However, you also need to know how the book relates to it. The book will give you more information and you're responsible for it. You're not responsible, though, for other disorders in the book that we don't talk about. I hope that is you understand that. Before we even start talking about pediatric respiratory disorders, I want you to know two emergency things that are medical emergencies with children in respiratory system. One is if they have a depressed respirations or diminished breath sounds. That's a medical emergency. The second thing, if it's a baby and it's doing respiratory grunting, that is also a medical emergency. And I would write that down. I would memorize it. It'll help you for the future. So it's important to know the signs of hypoxemia in children for all of the respiratory issues. So on the left, you have all your early signs that you're going to see first as hypoxemia sets in. And on the right, you have your late signs, and that's after the child has been suffering from the early signs for a little while and with no relief. It goes into the late signs. So this slide has the information you need to know. If I were you, I would put it on some little flashcards and memorize it. There's no other way to go about it. That way, when we talk about different issues, or if you get a question about different issues, you can put it together. Oh, this is bad because it's this and this and this. So one of the mildest things that we'll talk about is allergic rhinitis. And it's usually caused by seasonal reaction to allergens, most often in the autumn and the springtime. What you're going to see with the kids are like a runny nose, watery rhinorrhea, sometimes nasal obstructions, itchiness of the nose, eyes, the pharynx, and the conjunctiva. And these kids generally will snore at night, acting fatigued or malaise, complain of headaches, and poor performance in school is noted. These pictures are pictures you probably should know a little bit about, which is typical with children. The first one is the allergic salute, and it's caused by the second picture. The kids with the itchy nose and watery eyes, they keep pushing on their nose, rubbing their nose, and it causes this little crease in their nose that doesn't go away after a while. The last one is called allergic shiners, and you will hear this term often, and they're either red or blue little bags under the child's eyes from rubbing their eyes so much. Tests that are done for allergic rhinitis are usually done 3 years old and older, because if any symptoms of allergies appear between 1 and 3, they may disappear, and there's no sense putting the kids through this. Plus, usually they're mild. Kids under 1 are usually diagnosed with allergies. A nasal smear will be done, and as well as some blood exams to see if they have elevated eosinophils. As they get older, skin tests and various challenge tests are done for the kids. As the nurse, you should talk to the family about what they think could be the cause of the allergy and tell them they need to avoid allergens. A lot of times it's mold and pollen, but sometimes it's dust, cat dander, mold in the home. Give nasal corticosteroids, which is usually the first line of treatment. If the child is generally over 1 year old, they can have antihistamines beta-adrenergic decongestants, mast cell stabilizers, leukotriene modifiers, and ipratropium. So the next disorder that falls under pediatric respiratory issues is tonsillitis. And tonsillitis refers to inflamed tonsils, which is usually accompanied by pharyngitis and is often caused by a virus or a bacteria. Contributing factors is exposure to a pathogenic organism. And another contributing factors is we see it in young children. In fact, we see it usually between 4 and 7 years old, because this age group has a susceptibility due to their immature immune system. The assessment we'll find on these kids is usually bad breath, which is halitosis. Snoring, their tonsils are so large and sometimes their adenoids are also swollen that they snore. They usually will have a nasal sounding voice. They'll complain about difficulty swallowing and breathing, and they'll be mouth breathers. Their tonsils will be have edema and will be inflamed and red. They may complain about difficulty hearing due to blocked eustachian tubes. The throat pain that worsens with swallowing, a lot of times they'll have fever, a persistent cough, possible positive throat culture for group A beta hemolytic strep. And if a child chronically has strep throat, we start really considering them having a tonsillectomy, because their tonsils, instead of protecting the child from bacteria, entering the body, it's actually harboring either a virus or bacteria. Tests that can be done, and generally these first tests are to see if the child has strep or if it's viral, as a throat culture or a rapid strep. A lot of times they'll do blood work, a CBC, to see if they have elevated white cells, if it's bacteria, or if there's, a virus going on. And they'll check their clotting times before they'll do a surgical procedure, because, believe it or not, the tonsils are very vascular, and any time that they are removed, the child is at risk for, bleeding. Grading the tonsils is something that's kind of, fun to do nowadays, and you can do it. And I have the tonsil grading actually at the bottom. And if you look into a child's mouth and they have swollen tonsils, you're going to have to grade them. But believe it or not, the grade of +1 or +2 is actually normal sized tonsils. As the children get older, their tonsils actually shrink so that between 7 and 10 years old, they're of normal size. But before then, their tonsils might actually be a little bit what you might call enlarged, because their body is, using these as a mechanism to protect them from bacteria or viruses entering their system. Grade 3 is considered an enlarged tonsil that is seen with an infection, and the infection could be treated and it may go back down to a 2. But a grade of +4 is very significant, and they're almost touching. And when the tonsils are just about touching, they're called kissing tonsils. The danger of this is, with these swollen tonsils, there's very little room for them to swallow something, and it can occlude their airway, and it's somewhat dangerous. So a lot of times with either grade 3 or 4, we'll see the kid complain of a sore throat. They'll have difficulty swallowing again, and they may, the tonsils will be red, and sometimes they'll be covered with exudate. Just for tonsillitis, maybe the first time or second time, we just give them, if they have positive strep throat, we'll give them antibiotics as ordered. We will give them some antipyretics if they're running a little bit of a temperature. They'll get analgesics for the discomfort. And if they have tonsillitis often, a tonsillectomy will be ordered. Other things they can do during the tonsillitis portion, we don't want the child to have a tonsillectomy if they're infected. Their tonsils the swelling has to decrease somewhat. So we teach the families to have the child go on a soft or liquid diet. They can use a cool mist vaporizer, cool liquids, and warm saline gargles will help if the child's old enough to do that. I always, when a child has had a positive strep throat or they've had tonsillitis and we know it's viral, once either they're on antibiotics or if it's viral, once it starts getting better, we have them get a new toothbrush. They can put the toothbrush in the dishwasher if they want and cleanse it that way. Ideally, a new toothbrush would be in order. Number one, if it's they're on antibiotics for strep throat, after 24 hours, they're no longer contagious. So we don't want them to use the same toothbrush that could harbor the strep. So they need a new toothbrush. If it's a viral, we don't know, but some viruses live on the surface. So we'd really just rather be safe. As the child starts feeling a little bit better, get them a new toothbrush so they don't reinfect themselves. However, after several tonsillitises or reports of tonsillitises, the child will usually go see an ENT to have tonsils removed. And preoperatively, we for the child, we prepare them and the patient and the parents for surgery. We make sure that their consents are signed properly. We make sure that the procedure is explained to the child and the parents. We take a look at their clotting times and report if they have some bleeding tendencies. Before they go to surgery, we'll get a baseline vital signs. We'll check to see if they have any upper respiratory infection. They won't want to do surgery in this situation if they have any indication at all that the child has an upper respiratory infection. And we actually check their teeth. And so will the ENT, and so will the anesthesia guy. They'll check to make sure there's no loose teeth, because they certainly wouldn't want to accidentally dislodge a tooth and have the child aspirated. The surgery is quick. It doesn't take very long to be done. But I'll tell you, people think this is a nothing surgery. The risks, of bleeding are very great. The other thing in general is it's not usually done to kids under 3 years old. Sometimes it is, because there is a risk that the tonsils will grow back if the child's very young. So the child goes off to surgery, and then post-op, we really, really discourage coughing, clearing their throat, or blowing their nose, because it can cause them to actually start hemorrhaging. We monitor for signs of hemorrhage, which will be frequent swallowing, repeated throat clearing, or hemoptysis. So remember, frequent swallowing is the very first sign of post-operative hemorrhaging for a tonsillectomy. We also monitor the child for airway obstruction, for any stridors, for drooling, restlessness, agitation, tachypnea, or cyanosis. We restrict food and fluids until swallowing with no signs of hemorrhage are observed. We start off with ice chips, sips of water, cool liquids, and ice pops. And that's usually about the first 24 hours. The child, number one, usually doesn't want anything else post-operatively. But number two, we don't want anything to irritate their throat. Once they are drinking some clear liquids or cool liquids, they are not to use a straw and do any sucking motion. That can also cause hemorrhaging. We refrain from offering red or brown foods or fluids that could be mistaken for blood. So we, in the hospital, if it's they're admitted or if they're in the post-op room, we don't give them any like red drinks, Kool-Aids or brown drinks. And we also tell the family that because once they take the child home, they're going to observe for hemorrhaging. We can give the child an ice collar. Usually within 24 hours, they are advanced to a soft diet. And they can generally have some mild narcotic analgesics on a regular schedule the first 24 to 48 hours. We want the child to drink, and it's going to hurt when they drink. So if we don't give them something for pain, they probably aren't going to drink. And then their throat's going to get dry, they're going to get dehydrated. Getting their throat dry can actually cause hemorrhaging. So we don't want any side effects at all of the surgery. So on a regular schedule, giving them something for pain is really recommended. So when the client education for the child and the family is we provide information about what to expect if they're going to be admitted. Most of the time this is done on an outpatient basis unless maybe the child's special needs. And we're going to teach them ahead of time what to expect after surgery. We're going to teach them to avoid irritating or spicing foods for the first week. We'll teach them to avoid gargles or vigorous toothbrushing. We don't want anything to cause a hemorrhage. We're going to talk to the family about strategies for continued pain management and definitely give the signs of hemorrhage, respiratory obstruction, and when to seek emergency care. It's important to instruct the family to notify the healthcare provider if the child develops a persistent cough, has severe ear pain, or a fever. And the yucky pictures are the tonsils removed. Once the tonsils are removed, at first, when you look in their mouth, to make sure nothing's dislodged or, that it's not too swollen, you'll see little red circles in the place of the tonsils. But after about 24 hours, generally, you'll see the new skin forming, and it'll be looking kind of yucky. It looks like little white, and some people think it looks pussy, but it's really not. It's white, new skin that eventually turns gray, then black, and then looks normal. So this is just taking the tonsils out. We're not talking about an adenoidectomy, which sometimes has to be done if they're severely swollen, but it's not routinely suggested that they all have their adenoids out just because they're having their tonsils out. So nasopharyngitis is also known as the common cold. It's self-limiting virus that can persist for 4 to 10 days, and generally with little kids, we see it for almost 2 weeks. The child will have nasal inflammation, dryness and irritation of nasal passages, and the pharynx, a little bit of a mild dry sore throat. A lot of times they'll have a fever. They'll have decreased appetite and restlessness because they just don't feel well. Nursing interventions is we can give antipyretics for fevers, encourage rest. The body heals when it's resting. Provide vaporized air, cool mist vaporized air, not hot. Hot is dangerous when the child is young because they may turn it over on themselves, number one. And number two, hot actually won't let the child rest and sleep. It'll actually help them produce mucus and cough, cough, cough. We want to soothe that throat, help them sleep, and we want to promote safety. If the child is older, they can have decongestants, and I think your textbook says over 6. Sometimes they're given over 2. Cough suppressants are only to help the child sleep. We really don't want to stop them from coughing. We don't want this to turn into a pneumonia from mucus settling somewhere. So we do want them to sleep. Rest is important, so we may give them a cough suppressant at night or for naps, but not during the day. Antihistamines generally aren't recommended because it dries out the nose so much in the throat that it can break capillaries and cause the child some more uncomfortableness. And it's a virus, so we do not give antibiotics. So the next big problem due to having frequent colds is otitis or an ear infection. We're going to start off with otitis media. Otitis media by itself is an ear infection. It can be either viral or bacterial, but it's most often bacterial. Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis can cause it. Most often it's Streptococcus pneumoniae. Otitis media is the most common reason children receive antibiotics. And in fact, your book, interesting enough, says it accounts for 15 million prescriptions to be written per year. Pretty interesting. It can also be caused by a virus such as RSV or rhinoviruses, influenza, or adenoviruses. The reason little kids, and we don't see it so much after, they get a little bit older, get ear infections, is when they're young and under 3 years old, their eustachian tube is very, very short, and it's actually curved downward. So the fluid goes right down to right behind, the eardrum. It settles there. Gravity pulls it behind the eardrum and it settles. As a child gets older, like over 3 or so, our ear canal starts to straighten out and we don't see it so often. So otitis media is an ear infection and it's a swollen eardrum. Little kids will pull on their ears and let us know sometimes. It hurts a lot. When we look in with our otoscope, we'll see bulging red or opaque eardrum. Sometimes we can see and see some drainage in there. It can be, the kids could have a fever. They could be anorexic. They could be crying. Your book calls it sleep disturbances. What happens then, if there's fluid backing up from their nasty cold behind that eardrum, and when they go to sleep at night or their naps and they lay on that side where the fluid is backing up behind the eardrum, it causes a lot of pain and discomfort, and the child will awaken crying or complaining of an ear infection. Otitis media can cause the child to have vomiting and diarrhea, and many times we'll find that their lymph glands are enlarged. Generally, unless people want to go in and culture it, we treat it like an infection and they go on antibiotics, and within a couple of days their symptoms are starting to feel better, and as their cold goes away, so will their ear infection. If we treat the infection and as soon as their virus part of their infection goes away, the kids start feeling better and the complaints are less. If, in fact, though, we wait a while, the otitis media will be with infusion, which is what you'll sometimes see, and as I know, it is called serous otitis media. And that means that now there's fluid sitting on that eardrum that's not going away. It occurs in at least 80% of preschool children. And it's a collection of fluid in the middle ear. And sometimes they have symptoms and sometimes they don't. There's a decreased mobility of the eardrum. It can't vibrate because of the fluid sitting there. When we look in with an otoscope, their eardrum appears retracted, and you can see like the yellow pus, or sometimes they call it gray. Sometimes the kids will complain of tinnitus, they'll hear ringing in their ears. The ones that can talk will complain that they feel like something's in their ear or feeling a fullness. I had a little kid come in and say that he felt like he had bumblebees in his ear. He could hear buzzing, and what it was the fluid moving around in his ears. If it's not treated, the child will have a hearing loss, and while the fluid's in there, they'll have a temporary hearing loss, but not treated, they will have a hearing loss. And because it is the middle ear, they might have problems maintaining their balance. This is treated the same. It's treated with antibiotics and sometimes even decongestants to dry the fluid up. If it's not treated, that fluid pressure on the eardrum will actually puncture through the eardrum and cause a little hole, and it'll cause drainage, pussy drainage, to come out of the ear itself. Believe it or not, it's really severely painful when they have the fluid in their ears. The serous otitis media is the most painful one. And once the eardrum ruptures, the pain goes away because, there's no pressure there. But it needs to be treated so they don't lose their hearing. So interventions for otitis media and for otitis media with effusion is antibiotics, and you'll have to instruct the families to take all the antibiotics till they're gone, not until the child feels better, because generally they'll feel better in a couple days. You need to watch them for fever and treat a fever if that's the case. After several otitis infections in a year, the child will be sent to an ENT doctor. And it's up to the ENT to determine how many infections that he considers serious enough to do surgery and put in PE tubes or a myringotomy. Sometimes we send kids to the ENT even though they may only have 1 or 2 ear infections, but it's when the antibiotics aren't working. So a child comes in, sure enough, he has otitis media, and the first drug that we usually give them if they're not allergic to penicillin is Amoxo. And they come back to be rechecked because a lot of kids can't tell you if they have an ear infection. And now we notice that not only has it not gone away, but it's now with effusion, it's worse. You could see the fluid and it's worse. So we'll give them the second antibiotic on the latter. They come back in a week or so to see if it's improving, and it's still not improving. And once we need to go to the third antibiotic on the ladder, each one hits a different bacteria. It's usually time to go see an ENT, because having an ear infection for this long, which usually by this time is almost a month, really can damage the child's hearing. And these PE tubes that you can see at the bottom actually will drain the fluid from behind the eardrum and let it drain out so that now the child can hear again and the fluid isn't sitting there brewing more bacteria. The tubes don't stay in real long. Generally, they'll stay in 6 months to a year, but sometimes they fall out on their own sooner. They are in different colors. The real small ones from where I'm at are blue, and bigger ones used are usually red. But they're put in just to drain that fluid for a while. It's usually up north, they usually put them in just in the beginning of the winter season, which is cold and flu season. And it's because they want them to last through that cold and flu season. So every time the child gets a cold, the secretions from the cold will drain through these little tubes and not back up behind the eardrum and cause discomfort and hearing loss. As I said, they don't stay in a long time, generally 6 months to a year. So if they put them in up north, generally around November when the weather is pretty bad and kids tend to get colds. By the time they're ready to fall out, it's spring and the child may not need them any longer. As the child, when they're little, their ear canals are on an angle downward, and gravity will pull the secretions from their cold back to the eustachian tube. It just drains downward. After a child is 3 years old, their anatomy changes, and slowly that ear canal begins to straighten out. So generally speaking, we don't see a lot of ear infections after 3 years old. It's usually just getting them through the first 3 years. although there's always some kids that don't read the book and takes their eustachian tubes a lot longer to straighten out when we see them. So otitis media and media with effusion as the ear infections that you know, most times bacterial, it can be viral, generally it's treated with antibiotics. A lot of ear infections in 1 year will cause the child to go to ENT. ENT generally will do surgery, a myringotomy, and put the PE tubes in, allowing the fluid from behind the eardrum to drain out every time the child gets a cold. Therefore, the child doesn't have many ear infections. The PE tubes are short-lived. They don't stay in that long, generally speaking, and can fall out usually anywhere from 6 months to a year, and usually the child has no idea they're falling out, and the mom will find it in their bed. Every now and then they don't fall out, and after a year or so they need to be surgically removed. Otitis externa is different. Otitis externa, if you look at the picture, the last picture on the right, is usually another name for it, this will explain it to you, is swimmer's ear. And it's not from the fluid backing up behind the eardrum. It's the other way. It's from outside to inside. It's backing up in the ear canal itself. Generally, it's caused by fluid sitting there from either bathing for a little child or swimming. And it's not drying up like we want it to dry up. And it causes a warm, moist, dark area will brew infection. So this child will be severely in pain and will cry every time you even go near his ear, touch his ear. The external ear is very painful. And sometimes it's so bad that it travels down to his jaw. So this needs to be treated. And it's treated generally from the outside in with antibiotic ear drops to clear up that ear canal. Now, when it's really severe and it's in the jaw, many times they'll get both. They'll get oral and ear drops. But in general, it's the ear drops from external to internal that is given for otitis externa or swimmer's ear. So I had these pictures in one of my previous PowerPoints, and I just thought it'd be kind of cool to look at this. So when you're looking in with an otoscope, and you see a child that's had a lot of ear infections, the first thing you might see is the injected vessels and the altered shape of the cone of light from shining in, and that'll tell you that the kid has a lot of inflammation in that eardrum. The second picture is more a definite serous otitis, and you can see the little fluid bubbles in the ear behind the eardrum. So we're going to talk about croup, and actually it's called croup syndromes. There's acute spasmodic laryngitis, which is the most common and probably the mildest form of croup. Acute laryngeal tracheal bronchitis is a little bit more serious, and then we have acute epiglottitis, which is very serious. So we'll start with the acute spasmodic laryngitis. It's usually viral, and we think it could be possibly related to allergies. We do know that when the seasons change drastically, kids that are prone to croup will start this acute spasming, probably up north, where it goes from fall to winter quickly, and then again from winter to spring, like in a day. This is where the children are generally 1 to 3 years old, generally speaking. They go to bed well, and then usually what they call the twilight or midnight, the child will wake up with this shortness of breath, dyspnea, barking, metallic cough, or we would call it like a seal cough, stridor, hoarseness, and restlessness. Usually during the day, the symptoms disappear. So for these kids in general, If the parents are comfortable, they could treat the child at home with a cool mist vaporizer and just staying calm and encouraging quiet activity. If the parents are kind of nervous about this, they may take them to the ER. And in the ER, the child will get some steroids and racemic epinephrine. The steroids are usually for 3 days. This type of croup usually only lasts 3 days or 3 nights. The child is absolutely fine during the day. They do not have a fever. It's mainly this barky seal-like cough that bothers the child and the hoarse voice. The second one, the acute laryngeal bronchitis, is a tiny bit more serious. It still is caused by a virus, which could be RSV, which we'll talk in a few minutes. It could be mycoplasma pneumonia, could be measles, or one of the influenzas. We see this in infants and child younger than 2 years old. It's a gradual onset of symptoms. So it's not something that just spontaneously shows up in the middle of the night. The child usually is beginning to not feel well, and slowly he'll start with this inspiratory stridor, barking, a brassy cough, hoarseness, restlessness, irritability, substernal retractions, and now we see a low-grade fever. Symptoms are usually worse at night, but they can appear during the day. Sometimes the acute spasmodic laryngitis will turn into the acute laryngeal tracheal bronchitis after the 3rd day. Most of the time, the acute spasmodic laryngitis disappears into a nasty cold. The acute laryngeal tracheal bronchitis sometimes starts off as a little bit of a cold and turns into this uncomfortable situation. Treatment for it is the cool air that take the child outside, or a cool mist if the child's pretty mild and not so severe. If the child acts very restless and has a lot of substernal retractions, it's suggested that the family takes the child to the ER, and they're given steroids and oral or IV fluids. They're generally given a nebulized racemic epinephrine treatment, and they usually get nebulized budesonide, and they usually go home with that for 3 days. Most of the time, these children are fine. The temperature is low grade, so we usually don't treat them. The main thing, again, is the cool mist vaporizer and keeping the child calm. The last one is more serious, and thank goodness for the HIB and the Prevnar vaccines. We don't see it as often as we used to. It's acute epiglottitis, which can be very life-threatening. It's generally bacterial, and it's usually the H. flu meningitis that causes it. Remember that the acute spasmodic laryngitis or the acute laryngeal tracheal bronchitis, if it doesn't go away in a few days, can turn into, a bacteria will form and they'll end up with acute epiglottitis. We see it mostly in 2 to 5-year-olds, and this is something that goes from a mild little barky cough and progresses rapidly. In fact, the child may start off with just that nighttime barky cough, and then all of a sudden they start coughing, and we hear a muffled frog-like voice, but no coughing. Remember, when kids change quickly, it's very dangerous. It's not like, oh boy, they're getting better. It's if they go from something mild and then all of a sudden stops, usually something's wrong. The child will have a stridor, and one of the telltale signs is they will assume a tripod position with the chin pointing out, the mouth open, the tongue protruding, and they'll be drooling. These children will have a high fever, so it sets it apart from the others. Dysphagia, they have dyspnea, muffled, frog-like voice, tachypnea, and tachycardia. This is a medical emergency. So the child will be restless and afraid. They can't breathe. The most important thing is for the nurse to remain calm and have the parents remain calm and try to calm the child down. The child can sit in the parent's lap. Nothing should be done until the child is a little calm. But nursing interventions is to have an intubation tray and a tracheostomy tray at the bedside. It's diagnosed with a lateral neck x-ray to make sure that the airways are open. The kid is given antibiotics. They're put in droplet precaution for the first 24 hours until antibiotics have clicked in. They're given corticosteroids, humidified oxygen, IV fluids, and the child is very frightened. Remember, IV fluids, and usually they're made NPO because of the type of breathing they're doing. They will aspirate. It's important to keep the child calm and from crying and getting upset. The nurse should encourage a position of comfort, which usually is, semi-Fowler's to high Fowler's position. Droplet isolation, provide calm reassurance to the child and caregiver, monitor oxygen sats, and ensure that the intubation equipment is at the bedside. One of the most important things, you'll get this child into the ER, you'll do their vitals, you'll hook them up to monitors, you'll put the oximeter on them, you'll put them in a high Fowler's position, you'll be very calm, you'll get the healthcare provider. But meanwhile, don't look in their mouth. We never put a tongue blade or a culture swab in their mouth, because if the child gags, it can cause the airway to close up. So bronchitis or tracheobronchitis is something that a lot of us get. It's an upper respiratory infection and inflammation of the large airways. It's self-limiting and requires symptomatic relief. It's a virus, symptomatic relief. In fact, it's either viral or many times it's walking pneumonia that causes it, mycoplasma pneumonia that causes it. We see it a lot in children that are 6 years old and older. It is a persistent, dry, hacking cough as a result of that inflammation, and it's usually worse at night. So there's no antibiotics, it's viral, so it's treated symptomatically. And one of the things that they will treat these kids with is at nighttime, they will give them some cough medicine to help them rest. But during the day, they won't, because it actually will suppress the child from coughing up any secretions that might be hanging out there. And maybe we want to cough it up so it prevents a pneumonia in these kids. The other thing that we usually give them is analgesics. They'll complain that their chest hurts, so we'll give them some analgesics because they cough so hard. And if they run a low-grade temperature, they can have antipyretics. Some other nursing interventions would be to give them a pillow to brace their chest if it hurts so bad. One thing interesting enough is you probably heard people say, oh, they have chronic bronchitis. Well, if an adolescent has chronic bronchitis, we know now that they should be screened for either marijuana use or tobacco use. So this is bronchiolitis, not bronchitis. Bronchitis is that hacking, dry cough that we see in kids, usually, kindergarten, 6 years and older. Bronchiolitis is usually what we see in infants. It's an acute inflammation of the bronchioles, and we usually use bronchiolitis for children younger than 2 years old that have wheezing with their coughing. It's most often either a virus or a bacteria, and the virus most common is RSV, but it can be rhinovirus, parainfluenza, adenovirus, and influenza viruses. Very rarely is it bacterial, but it can be. About 3% of the infants diagnosed with bronchiolitis will require hospitalization for care such as suctioning. The virus enters the mucosal cells and ruptures the cells, creating debris and increased mucus production, and causes bronchial spasm and obstruction. Air gets trapped in the alveoli and is absorbed by the blood, causing atelectasis. We see reduced lung compliance. Many times the perfusion is poorly, they're poorly perfused, so they need ventilation. If they don't get it, they could have hypoxemia and hypercarbonemia. The risk for pneumonia increases because of the tissue damage. So the assessment of the baby will be mucus, which will cause the baby to wheeze and have crackle sounds. If apnea, especially if it was a premature child, nasal congestion, low-grade fevers. Sometimes it's a dry, non-productive cough. And I'm going to tell you, it's a high-pitched cough. It's different. Your book says wheeze and or crackles or reduced air sounds because of air trapping and hyperinflation. Tachypnea with a respiratory rate above 60 breaths per minute, and it can progress to severe respiratory distress, exhaustion, and failure. Usually the kids will need a chest x-ray to see about the pattern of hyperinflation. And they'll take a good look at the polymerase chain reaction. Nursing interventions is, of course, cardiorespiratory monitoring, IV therapy, sometimes NG therapy. You know, these kids are breathing really, really fast, and the risk of aspiration is great. So we usually don't let them oral feed. Occasional, if it's a breastfed baby, you know, they may be able to try, but generally we don't. So they get IV fluids or NG fluids. They need supportive therapy via supplemental oxygen. They need high flow or positive pressure humidified oxygen. Good hand washing. If they're premature, they'll get surfactant. They'll have contact and airborne precautions. And we want to prevent the spread of the organism. They'll use nebulized hypertonic saline to keep, that the airways moist and open. They'll do pulmonary hygiene. They'll do chest PT, postural drainage, and suctioning. So kids that are born generally somewhere between 29 to 35 weeks gestation, and who are 3 months or younger at RSV season. RSV season is during flu season, so it's usually September or October through May, your book says. So kids that are born early, really early, 29 to 35 weeks, that are only 3 months during the season, and either they had some chronic lung disease when they were born that required oxygen, or they have a congenital heart defect. They require this preventative medicine called Synagis, or the generic name is, I'm going to spell it, I have a hard time pronouncing this, PALIVIZUMAB, and the brand name is Synagis, and that's actually how I know it. So if this premature baby, very premature too, not 36 weeks, premature, is 3 months old during RSV season, and they had some kind of lung difficulty at birth and needed oxygen, or if they have a congenital heart problem, they will be able to have this monthly injection of Synagist or Palvizumab. I just don't know how to say it, I'm sorry. It is based on the child's weight, and it's IM. So every month the child will go to their pediatrician where the medication is delivered, and they'll be weighed, and then the correct dosage will be drawn up and given to the child IM at the same time every month during RSV season, October through May. They usually will do it for 1 year, and then they don't usually get it after that. The risk of, it causing respiratory demise after a year is not so great. So it's very, very costly. Most insurance will pay for it, not all. In general, with a child that has bronchiolitis, no matter if they were premature or not, under 2 years old, it's a serious thing. So the parent care will be to teach the parents how to use the bulb syringe. If it's RSV, how to avoid the spread of RSV with hand washing. To keep the baby hydrated, especially if they're at home now and it's bad, but the baby can tolerate a little oral feeds. And I'll tell you, just for your own knowledge, generally we don't give them much formula. We'll water down their formula, so because formula is kind of thick and it might be difficult for the baby. For a short time, we might water it down. The parents will be needing to learn how to do the saline drops to keep the secretions thin, to monitor the temperature and when to give the antipyretics, and to give, they call it a vaccine in your book, the RSV vaccine schedule. It's actually, I guess it is. We call it a preventative measure, so I guess it is. These children need to be not exposed to tobacco smoke and air pollution. They should be kept indoors during this time. Teach the parents to assess for respiratory distress and any change in symptoms which are significant. Symptoms, when these kids get bronchiolitis, it's usually for 2 to 3 weeks. So this is a serious thing. This isn't just, a 10-year-old with bronchitis and that honky cough. This is a little baby that could possibly die from this. These kids really get fatigued from coughing so much and breathing so fast, so cluster care is very important. You'll need to teach the families when they should notify the healthcare provider. And the symptoms you would tell them is worsening respiratory distress, and how they can tell that's happening, as you'll show them how to tell if there's increased retractions, increased respiratory rate, or an increase in adventitious respiratory sounds. Anytime these children appear more ill than they were the day before, or are not able to eat or drink or sleep, they need to go to the ER and they'll be hospitalized. So bronchiolitis in the full-term infant under 2 years can be treated at home, and is serious, but not as serious as a child who was born premature before 35 weeks and had, when they were born, a little lung issue where they needed oxygen, or they have a cardiac anomaly, and they're 3 months old when respiratory RSV season begins. Those kids need to be hospitalized, and they will also be given the RSV vaccine from October until May. So pneumonia. Pneumonia is an inflammation of the lung parenchyma leading to consolidation. It can be viral, and usually viral pneumonia is called mycoplasm, but it also can be caused by RSV, and it can be bacterial, which is a little bit more serious. What we'll find with our kids, and we're going to go mostly bacterial. Bacterial can be Streptococcus pneumoniae, or Group A Streptococci, Staphylococcus aureus. And then our viral is usually Mycoplasma catarrhis or Mycoplasma pneumoniae. They're all treated as if they're bacterial, though. What you'll find in the child is usually a high fever, a cough that can be unproductive or productive of white sputum. Usually, mycoplasm, the kids don't have much of a cough when it's unproductive. And with pneumonia itself, the reason that the kids get it, it's because their cough isn't so productive and the secretion is being lodged in the lungs. The child will have tachypnea, retractions, and nasal flaring. They'll sometimes complain of chest pain because it hurts when they cough. Dullness with percussion, if you do percussion. Adventitious breath sounds. You will hear, if you listen with your stethoscope, rhonchi and fine crackles. The child usually is very pale, and some will actually be dusky or cyanotic. And sometimes what we'll see around the mouth is a little duskiness. And there's a couple of different terms for that. Circumoral cyanosis, and the other one is oromoral cyanosis. Sometimes their nail beds will be dusky. The child will be irritable, restless, and lethargic. Remember, when you can't breathe, you're usually very restless. They may complain of abdominal pain, diarrhea, lack of appetite, and vomiting. Mycoplasma pneumonia is known for the kid coughing until he vomits. Tests that can be run usually are x-rays to detect the presence of infiltrates. They will do a gram stain and a culture of the sputum in the bigger kids. They many times will do a nasopharyngeal swab, blood cultures. Really, in extreme cases, they'll do lung aspiration and a biopsy. It has to be pretty serious. And they'll do an elevated anti-strepsirrhine titer if streptococcal infection is present. So if you have a kid that maybe has like a strep throat, or their labs come back positive for strep, they'll do this titer to see just how serious the strep is. Now, for a child that has viral pneumonia, they don't get antibiotics usually. Occasionally, you'll see a viral pneumonia, and I want to tell you this because of us going to the hospital. They don't always follow the books in the hospital. Occasionally, they'll give an antibiotic so it doesn't go secondary, to bacterial. But that's generally only on older children. In general, viral is viral, and they'll give oxygen with cool mist. They'll do oximetry care, monitor their SATs. They'll give them antipyretics for that fever, and the fever's high. The child will be put on INO to make sure they're not retaining any fluids and make sure they're drinking enough. And they'll get chest PT and postural drainage. For the child that has bacterial pneumonia, first of all, they're the ones that are most fatigued, and so rest is encouraged. They'll get IV antibiotics. They'll promote increased oral intake to keep that secretion dense. Monitor INO. Administer antipyretics for fever. They'll receive chest PT and postural drainage. Their fluids will be IV fluids. They'll get oxygen, and their oximetry will be also monitored. Complications, unfortunately, with pneumonia can be very serious. And the first one is a pneumothorax, which is an accumulation of air in the pleural space. With those kids, if it's, they have pneumonia, well, you'll know that things are going downhill if they have dyspnea, severe chest pain, back pain. Their respirations become labored, and they have decreased oxygen sats and tachycardia. If that's the case, if this is your patient, and really the oxygen sats are usually one of the first telltale signs, you're going to prepare the client for a needle aspiration to be put into the pleural space. Most places usually have a tray that's called, pneumothorax needle aspiration. And what they'll do is they'll put a needle to aspirate the air, and then they'll insert a chest tube to close the drainage. Then you'll have to do chest tube care, which we'll talk about later. You'll have to assess respiratory status and administer oxygen as needed. The second, which I think is more common, I don't know if that's what your book says, complication is a pleural effusion, which is an accumulation of fluid in the pleural space. And with these kids, you'll see almost the same thing as you do with the pneumothorax. You'll see dyspnea, chest pain, back pain, labored respiration, decreased oxygen sats, and you'll see tachycardia. So once again, you'll do the same thing. You'll get the tray for the chest tube insertion to close drainage and put it by the bedside. You'll provide for the chest tube care. You'll monitor the respiratory status, and you'll give oxygen as prescribed. Kids with pneumonia are usually very, very tired. And actually, as they start perking up, they're getting better. They'll usually have an elevated white blood cell, and they'll see a high SED rate because inflammation's present, and a C-reactive protein. If they're getting to go home, you'll teach the caregiver to watch very carefully for aspiration. If their breathing is bad, they really at that time should not be drinking too much fluids, even though we want to push fluids. We want to elevate the head of their bed 30 degrees. We want to avoid, if it's a baby, overfeeding. If it's a baby, they really need to have frequent rest periods when they eat. And one of the things you'll notice with the baby is when they are given the bottle, that they need to be rested. If you see that they are sweating on the perspiration on their forehead, or if they have furrowed eyebrows. They need frequent burping. You'll have to teach the family antibiotic administration. And then tell the family that fatigue is common, and fatigue and a cough may linger for a few weeks. We have to be sure these kids get the pneumococcal vaccine. That'd be one way to prevent this from happening. We do see pneumonia, viral pneumonia, and we do see a little bit of bacterial pneumonia in all children, but the ones we see it the most in is children that are not immunized. So now on to the little guys. Respiratory distress syndrome, RDS, and mostly a premature baby. It's a condition of surfactant deficiency and an immature thorax. You may know it as a hyaline membrane disease. It results in hypoxia. It's most often seen in premature infants, but it can be seen in drug-exposed infants or neonates who are exposed to intrauterine stress, such as those babies that moms had preeclampsia or hypertension. So the contributing factors for these kids is prematurity, a diabetic mom or hypoglycemic, multi-fetal pregnancies, so, triplets, twins. We can see it in a cesarean section. We can see it in a baby that had cold stress, birth asphyxiation, a family history of RDS, sepsis, cardiac or respiratory abnormalities, premature rupture of membranes, and maternal use of depressants close to delivery. Your assessment will find the baby tachypnic, and the respiratory rate is greater than 60 breaths per minute. You'll see what we call peristernal or pericostal retractions. The baby will have nasal flaring, labored breathing with prolonged expiration, inspiratory crackles, really, really important here, expiratory grunt, and molting. That means that molting is where the baby has like a lacy blue-purple rash. An expiratory grunt, or a grunt in general, we call it a respiratory grunt, is always a sign of severe distress, and a child needs attention immediately. The baby will also have low oxygen saturation. They'll have respiratory or mixed acidosis, hypercarbemia, atelectasis, and as their condition worsens, the baby will become flaccid, non-responsive, have apnea, decreased breath sounds, and central cyanosis. In general, an emergency for pneumonia or any respiratory things with kids is decreased breath sounds and respiratory grunt. Those are an emergency. Get help immediately. Lab tests and diagnostic tests are arterial blood gases, chest x-rays, blood cultures, urine cultures, and cerebral spinal fluid cultures, and blood glucose. Therapeutic procedure and medications for these kids is mechanical ventilations, and they'll usually put on CPAP. Oxygen, IV fluids. They're usually NPO when they're at their acute phase because of the same thing as our bronchiolitis babies. We don't want them to aspirate. Total parental nutrition, exonerous surfactant, prophylactic antibiotics, caffeine to keep their heart rate up, intratropes, electrolytes, sodium bicarb. Wow, huh? Interventions. Okay, for the nurses to monitor responses to all their therapies, their respiratory effort, and their arterial blood gases. Excuse me. Monitor their vitals, their oximeter, and color in their pulses. Color means a lot with these babies. Suction only when necessary. Place in a prone position initially to decrease chest expansion. Place under radiant warmer or other controlled environment to eliminate heat loss and prevent cold stress. Now, it's important to encourage parents to hold, touch, talk to the baby as much as the status of the baby allows. Encourage parental participation in care. If the mom is going to breastfeed, she could pump and store the breast milk. They can assist you as the nurse with repositioning the baby. when the baby comes in, education is to orientate to the neonatal intensive care unit, explain all procedures, encourage kangaroo hold as condition allows. Kangaroo hold is skin-to-skin hold. The mom's shirt is opened or the dad's shirt is opened, and the baby's usually is only in a diaper so that they can have skin-to-skin contact. And there's been a lot of studies on that show that the babies improve quickly. And instruct how to pump and store breast milk. One other thing, we talked about respiratory emergencies being decreased breath sounds and respiratory grunts. One thing to remember is do not give anything by mouth to infants with a respiratory rate greater than 60 breaths per minute, or to children with severe respiratory distress. It's important to know that. So a complication of the respiratory distress syndrome, RDS, is bronchopulmonary dysplasia, or BPD. The kids with RDS almost always are ventilated for a long time, and then they're weaned to oxygen usually. Some of them, however, are actually on the ventilator a very long time, and unfortunately, it causes fibrosis of their airways. So BPD occurs in newborns who are born prematurely or have a variety of pulmonary disorders who require ventilator support with high pressure and oxygen in the first 2 weeks of life. It's kind of a sad thing, although I've seen good things happen. The pathophys is fibrosis or airways and marked hyperplasia of the bronchial epithelium. Increased fluid in the lungs as a result of the disruption of the alveolar capillary membrane. Causes overdistension due to damage to the alveolar supporting structures, resulting in air trapping. And fibrosis, airway edema, and bronchial constriction occurs. So what are we going to see with these kids that have this? Well, the assessment would be persistent respiratory distress. So every time they try to wean this little guy off the vent, they go into respiratory distress. They're dependent on high pressure supplemental oxygen. These babies become failure to thrive. They can't oral feed, and they end up having gastroesophageal reflux because of, the position of their lungs at that point, the hyperinflation of the lungs. A lot of them have pulmonary hypertension. So this is has been a big dilemma in the past. So what has been, I think, invented, and I'm going to say probably 10 to 12 years ago, and it's still an amazing machine, and most pediatric hospitals only have one or two. They're very, very expensive. They're just very rare, and it's called an ECMO machine, or ECMO treatment, and it's ECMO. And what this machine does is they take the child off the vent and put him on this ECMO machine, which is very similar to the heart-lung bypass machine, but the child can be on it for a little bit of time and slowly weaned to oxygen supplemental therapy, and without, taking the risk of the child being vent dependent for the rest of their lives and dying from the fibrosis. The long-term outcome for a child with BPD can be a child that's oxygen dependent. They generally will have visual problems secondary to the oxygen, feeding difficulties because, they've been on the vent and then the ECMO for so long. They generally will have a developmental delay and learning difficulties, secondary to their treatment. Long-term management is supplemental oxygen. And I'll tell you though, I have really and truthfully seen kids get off the oxygen. They're still tiny, so they're usually between 1 and 2 years old. Remember, they're very premature. And eventually they can get off of it if, things go well for them. They'll always need chest physical therapy because they won't be able, because of the fibrosis, to cough up the secretions. They'll need to be on bronchodilators and diuretics to counter the pulmonary hypertension. They're usually given anti-inflammatory medication. They'll have, for nutritional support, oral, formula, and NG supplements, because remember, they become failure to thrive. And the thing with these poor little guys is once they're on just oxygen support, they fatigue very quickly. So they usually start off, getting like a bottle, oral feeding, and then when they tire, they'll get an NG supplement. Many times they end up with a gastrostomy tube. These kids are in the chronic state of acidosis, so they'll get bicarbonate in their formula. It sounds horrible, but actually I've seen good things happen for these little kids, in the more recent time. Thank goodness to ECMO. Another respiratory disorder that we're seeing is pertussis, and the other name for that is whooping cough. Yes, there's a vaccine for it. So generally, we see it with kids before they've had all their series of vaccines, or kids that have not been vaccinated. It's highly contagious. It's a bacterial infection, and the name of the bacteria is Bordetella pertussis. It occurs mainly in children younger than 10 years old. The global burden was 16 million cases and 195,000 childhood deaths annually is reported. Peak occurrences in spring and summer. And we don't see it very much if the child's been vaccinated with their pertussis vaccine. We see in these little kids paroxysmal coughing attacks, and they're more frequently at night. They have intense effort to expel thick mucus, post-tussive emesis, and exhaustion. In between their coughing issues, they don't seem that sick, but usually they get that paroxysmal coughing and they can't stop coughing. After a cough episode, they'll have the characteristic whooping sound and gasping for air. That's where the name whooping cough came from. There's 3 stages of whooping cough. Stage 1 is just an upper respiratory infection, nasal congestion, coughing, rhinorrhea, watery eyes, sneezing that lasts 1 to 2 weeks. The second stage is intense coughing. In fact, they call it coughing fits. And this goes on for about a week. And sometimes very young infants will become apneic from the partial airway closure, and that will last 1 to 6 weeks. The third stage is chronic cough lasting up to 10 weeks or longer. And pertussis is known as the 100-day cough. So think about the struggles if this is an infant. Any age group, but the infants in particular become exhausted. So it's diagnosed by clinical presentation. They can do a nasopharyngeal throat culture, and usually it'll prove to be pertussis. Nursing interventions include drug therapy, monitor respiratory status, and give humidified oxygen. The child needs to be in droplet precautions. They need to maintain hydration and supportive care. Generally, because of this kind of coughing, aspiration is a huge problem. So these kids are either generally IV hydrated with, supplemental nutritional therapy. And if it's an infant, we have to try when they're not coughing to give them the pacifier so they continue their suck reflexes. And caregiver education. We have to really stress the importance of the DTaP vaccine. People just don't understand. We have to prevent the spread of infection. These kids need to be isolated. And one thing is we have to, if you tell the parent everything that's involved, they won't panic when an illness lasts forever. So we need to inform them that the child could possibly have this persistent cough up to 10 weeks after they've been infected. So cystic fibrosis is near and dear to my heart. I've taken care of an awful lot of kids. In fact, I worked with a doctor that developed the sweat test, the sodium chloride test for cystic fibrosis. So we have quite a few of these kids on our unit. And when I took care of them, they died very young. But now the life expectancy is close to 40 or more. So it's kind of exciting to me and encouraging that medical research has come a long way. And you'll probably be hearing my dog snore and Scarlett saying hi constantly because they're getting tired of me doing this. Cystic fibrosis is an inherited autosomal recessive disorder of the exocrine glands that causes the glands to produce thick, tenacious mucus. It affects the liver, the lungs, the GI system, and the pancreas. Both parents must be carriers of the genes, and that's carriers of the recessive trait. The gene responsible for CF is located on chromosome 7. Lifespan now is somewhere around 40 years. And it's been said that this is a complex disease requiring holistic approach. Mutation of the CFTR gene disrupts the function of the chloride channels, preventing them from regulating the flow of chloride ions and water across cell membranes. As a result, cells that line the passageway of the lungs, pancreas, and other organs produce mucus that is thick and sticky. Abnormally thick mucus leads to mechanical obstruction of the liver, small intestines, pancreas, and lungs. Usually kids, for the assessment, that have cystic fibrosis have a history of meconium ileus at birth. They usually produce foul, smelly, greasy, bulky stools. And they also complain of constipation. And the foul, smelly stools are called stegarrhea. They usually have a voracious appetite with poor weight gain. They have recurrent respiratory infections, persistent chronic cough with yellow-gray mucus. Their skin tastes salty if you kiss them. They're short of breath. They have dyspnea and wheezing. They have a positive sputum culture. Usually it's Pseudomonas, but sometimes it's Haemophilus influenza. When they are at their worst, they'll have a fever. They affect the reproductive organs, and the males will have a decrease or absent sperm count. When we look at the child for inspection, we'll see cyanosis, hyperinflation of the lungs, barrel-shaped chest, clubbing of the fingers and toes, a distended abdomen, thin arms and legs, delayed puberty, failure to thrive, hypoproteinemia, deficiency of fat-soluble vitamins A, D, E, and K. Once again, deficiency of fat-soluble vitamins A, D, E, and K. Test and procedures, they'll have a positive sweat test, which they call as the gold standard. It's actually now called the sodium chloride test. Cystic fibrosis is confirmed if the chloride is greater than 40 milliequivalents per liter for infants less than 3 months old, and greater than 90 milliequivalents per liter for over 3 months old. The sodium will be greater than 90 milliequivalents. There's usually a genetic marker. They'll do a stool culture, a sputum culture, blood glucose, chest x-ray, and abdominal x-ray when the kids are admitted. Now there's a lot of medications that are given to these kids. The one thing is they cannot digest food. Remember I said voracious appetite, but they're skinny? Okay, they cannot digest food. So anytime they put anything in their mouth to eat, they need to take pancreatic enzymes. So it's pancreatic enzymes to help digest food. And there's a few different brands. The most common is pancrelipase. Pancrelipase. However, I want you to look in your book. I can't remember what brand they had there. And then when we go to the hospital, if you take care of any of these kids, there's another brand they use in the hospital that I wasn't as familiar with. The kids will get inhaled and IV antibiotics, antimicrobial for lung treatment, and they usually get tobramycin, ticarcillin, and gentamicin. They'll get mucolytic enzyme, important to know this, mucolytic enzyme to decrease the viscosity of the mucus, and it's called Dornase alpha. Dornase alpha, DORNASEALFA. You must know these things. They'll get a short-acting beta antagonist, which is usually albuterol. They'll get a cholinergic antagonist, which is an anticholinergic. And they'll get, let's see, which is another brand is ipratropium bromide. They'll get fluticasone propionate. Let me spell this for you. I'm sure I'm not pronouncing it right. FLUTICASONE. Second word, PROPIONATE. And then I have slash SALMETEROL. Salmeterol. And tremors are when the child is on albuterol, and a dry mouth when they're on the ipratropium. So that's why they get that. They need vitamin C to improve absorption of meds. They need vitamins A, E, D, K, which are fat solubles. They usually are given a laxative or a stool softener. Okay, so you get the picture of this child. They are usually barrel-chested, skinny arms and legs. They're pale to gray with a little, sometimes cyanosis. They have clubbed fingers and toes with a little cyanosis there. They have chronic cough, and when it gets bad, they produce thick mucus, and they'll be wheezing and short of breath. The long-term complications of cystic fibrosis are nasal polyps, sinusitis, rectal polyps, rectal prolapse, hyperglycemia, diabetes, infertility, at risk for dehydration, poor absorption of fat and protein from diet, and reoccurring pneumonia. Now, these kids are usually admitted once or twice a year if they do well for what they call a tune-up. And they come in, and if they don't have a port, some of them do, depends on how often they're in. And the ones that only have to go in once or twice a year don't. And they usually try to plan it as they get older on, when there's no school. And the tune-up is they'll run, all their sputum cultures and stools and all that. And they make sure all their doses that they're taking at home is correct and helping them. They'll also give them triple antibiotics, as I mentioned before, to kind of kill any bacteria that's lounging around in their fat cells and whatever, to get rid of it. So nursing care is, of course, you need to know all the medications and their side effects. And you're going to have to assist with chest PT and postural drainage. And remember, we don't want to do chest PT and postural drainage just before they eat or right after. So it's usually an hour before they eat, so that they don't have any of this mucus and have trouble eating, or 2 hours after they eat, so that the mucus doesn't bring up everything that they eat. You're going to watch their vital signs and their oxygenation. If they don't have a port, you're going to have to get IV access and obtain sputum cultures prior to them going on antibiotics. You'll assist with aerosol therapy, and you're going to encourage physical aerobic exercise, which will prevent a pneumonia from that thick mucus. Oxygen is needed, but you'll need to assess for carbon dioxide retention. Family education should include emphasizing the importance of immunizations, equipment instructions, medication education, the need for regular appointments, and chest PT. The nurse should encourage a well-balanced diet, high in protein and calories. 3 meals with snacks and plenty of fluids. Pancreatic enzymes are to be given within 30 minutes of eating. For gastroesophageal reflux disease, you're going to administer a histamine receptor antagonists and motility medications. If the infant is breastfeeding, it may need supplements. May need GT supplements. Some of them have GT tubes in, the ones that I've seen in the hospital now for that. Monitor glucose, and cystic fibrosis related diabetes can be a problem because of the scarring of the pancreas. Administer insulin as prescribed, and you may be the one to be teaching about insulin and diabetes. So a lot of education goes into this. A lot of, at least when they're young. When they get older, generally speaking, the patient will tell you what they do and what they need. One thing I wanted to show you, and I don't know if that's my next slide. Let me look. It is now, chest PT is the top picture, but the bottom picture is the newer chest PT vest. And it's hooked up to this little thing, and it vibrates the child's chest. And the cutest thing I saw, when I was in the hospital, we didn't have that. So this has to be about maybe 10 years old, 8 to 10 years old. Now I've seen quite a few of them, and some of my patients even have them. But what the cutest thing I ever saw the first time I saw it was a little 3-year-old that said, "Oh, when am I going to eat?" And the nurse that was taking care of the child says, "Oh, your food's probably going to be here in about an hour. Oh, I better get in my vest." And the little 3-year-old ran over, got the vest, put it on, and sat in a chair and let it do his thing. It was the cutest thing. So long-term complication is, they're constipated a lot. So they a lot of times get rectal polyps. They get polyps in their nose due to the thick mucus and always blow in their noses. The other complication for these kids is really psychological, psychosocial problems. If they're sick a lot, they're in the hospital a lot, and they miss out on school and peers. The other thing is they they can't do as much as other kids. They get fatigued, they start coughing and throwing up. So they need a lot of psychosocial help and a lot of love from us. Remember that their diet, once again, is high calories. And can you hear that bird? High calories and I want to find where I said it because this is important. High calories. And I want to say high protein. Of course, now I can't find it in my notes. I believe it's high calories and high protein. Remember that they cannot put a bite of food in their mouth without taking their pancreatic enzymes. And sometimes it's, as the kids get bigger, it's 6 and 10 capsules. They're all capsules. They're time released. Asthma is next, and please, please, please read your book. I have the pages there. The medications are in your book, all the tests are in your book, and I'm just, thinking you need to read it. It's probably better than me just reporting it to you. I'm going to talk a little bit about asthma, which is a chronic inflammatory disorder of the airways that results in intermittent and reversible airflow obstruction of the bronchioles. The obstruction occurs either by inflammation or airway hyperresponsiveness. Asthma diagnoses are classified into one of 4 categories based on the effect of the child: intermittent, mild, persistent, moderate persistent, and severe persistent. So let me get my little cheat sheet here on this. I only have 4. I think your book lists 5s. 2, 3. No, it doesn't. So I'm right. Okay. So mild intermittent is symptoms that last twice a week. Mild persistent is symptoms occur more than twice a week, but not daily. Moderate persistent is daily symptoms occur in conjunction with exacerbations twice a week. Severe persistence are symptoms that occur continually, along with frequent exacerbations that limit the child's physical activities and quality of life. So risk factors is a family history of asthma and a family history of allergies. We see it more in boys than in girls. And another risk factor is exposure to smoke, low birth weight, or being overweight. I've got this cute little picture here. I think it's an old Pinterest picture. Triggers of asthma is allergens, mold, cockroach antigen, dust mites. Outdoors, it could be grasses, pollen, trees, shrubs, mold, spores. Irritants could be tobacco smoke, wood smoke, odors, sprays. Other triggers could be exercise, cold air, or changes in weather. Environmental change, new school, new home. Infections and colds. Animal hair, dander. Some medications can be a risk factor, such as aspirin, non-steroidal anti-inflammatory drugs, some antibiotics or beta blockers. Strong emotions, which is interesting: fear, anger, laughing, crying. Some conditions like GE reflux, tracheoesophageal fistulas. Food allergies or additives. Endocrine factors, menses, pregnancies, thyroid disease. Interesting enough, a long time ago, and I'm going to tell you I was kind of young because I have a sister with severe asthma. There was a lot of studies that were saying that asthma was all psychosomatic, and it was brought on by psychosocial issues. So I find it, whenever I read strong emotions, I always remember how horrible that was for my parents because they didn't believe that at all, although they know it can affect it. My sister would have asthma attacks when she was exposed to a cat. The cat and feathers were the worst for her. So it was a lot for them to deal with at the time. What we see in the child is a chest tightness, a history regarding current and previous asthma exacerbations. We want to know the onset and the duration that the child's been having problems. We want to know the precipitating factors and if they changed any medication regimes. We want to know medications that relieve their manifestations and other medications. And we want to know their self-care methods used to relieve the manifestations. Physical assessment findings will be dyspnea, cough, an audible wheeze, coarse lung sounds, wheezing throughout, sometimes crackles, mucus production, restlessness and irritability, anxiety, sweating, use of accessory muscles, and a decreased oxygen sats. Some of the lab tests could be a CPC to see if they have an infection or something going on. Diagnostic procedures. The pulmonary function test is the most accurate test for the diagnosis of asthma and how severe it is. And so when they think the child has asthma, they'll do the test, and then they'll start medication, and then they'll repeat the test to see if it's helped the child. And then it's done every 2 to 3 years. Another diagnostic procedure is the peak expiratory flow rates, which measures the amount of air that can be forcefully exhaled in 1 second. Each child needs to establish their best expiratory flow rate. Sometimes they'll do a bronchial provocation test, which exposes the child to methacholine, cold air, or a histamine, and then do an exercise challenge. Skin prick testing allows identifying allergens that can trigger the asthma, and a chest x-ray looking for hyperexpansion and infiltrates. So nursing care for these children is you need to assess their airway for patency, their respiratory rate, their symmetry effort, and the use of accessory muscles. You need to assess breath sounds, monitor for shortness of breath. An absence of wheezing can indicate severe constriction of the alveoli. So if you walk in a room in the ER and the kid's wheezing really bad, and then it's audible, and you leave to go get maybe the preferred provider or get help, and you come back and there's no audible wheezing, it actually doesn't mean the child's better. It means the child's worse and they're not exchanging air. So that's something to keep in mind. It's a priority to look for. You need to monitor their vitals and their oxygen sats and check their labs, including blood gases. You want to have the child sit up properly to maximize their ventilation. And if oxygen therapy is ordered, you want to initiate that. Always have an endotracheal intubation equipment nearby, always. Be sure you're calm and make sure everyone around the child is calm. And many times you'll have to initiate and maintain IV access. Encourage the appropriate vaccination and prompt medical attention for infections. Sometimes these people get used to it and think they can handle it on their own. They sometimes don't want to do vaccinations because they think it might make the child worse. And a lot of times they'll let infections go, such as an ear infection or strep throat, which actually could cause another asthma attack for the child. As a nurse, you'll administer medications, and you'll know the medications, the side effects, and you'll have to teach it to the family and the child. So look in your book for the bronchodilators, which are inhaled. Remember, whenever the child uses an inhaler, afterwards they need to rinse their mouth out so that they don't get a fungus on their inner mouth. And it also causes dry mouth, so it's really good that they rinse their mouth out afterwards. They'll also get anti-inflammatory agents such as corticosteroids. They'll get leukotriene modifiers and mast cell stabilizers, monoclonal antibodies, and sometimes they are lucky enough to get combined medications in an inhaled amount. So again, with any of these drugs, know the drugs. You can find them in your book. Your book has a wonderful 2 pages of them. Know how they're given, if they're inhaled, if they are, PO, or if they're nebulized. Nursing considerations for that is observe the oral mucosa for infection secondary to use of the inhaled steroids or medication, assess their weight, their blood pressure, the electrolytes, glucose, and growth with oral corticosteroid uses. Encourage the child to drink plenty of fluids. Encourage them to take the oral corticosteroids with foods. Insist that they rinse their mouth out after the use of the corticosteroid inhaler. Teach the family to watch for redness, sores, or white patches in the mouth and report it. Teach the family to follow prescription for medication administration. It's important to help the family identify personal trigger agents and help the child avoid triggering agents. Talk to them about it. You need to put together a care plan so the parents can take that home and follow it. Instruct the child how to properly self-administer the medications and how to use the peak flow meter. Stress the importance of keeping the child immunized and encourage regular exercise as part of their therapy. Sometimes the children require an inhaler before exercise. A complication is status asthmaticus. This is a life-threatening episode of airway obstruction that is often unresponsive to common treatment. It will include wheezing, labored breathing, nasal flaring, lack of air movement in lungs, use of accessory muscles, distended neck veins, and risk for cardiac and respiratory arrest. So nursing action should be, if they come in status asthmaticus, to monitor their stats continuously. So an oximeter would be important. Place on cardiorespiratory monitoring. Position the child sitting upright, standing, or leaning slightly forward. Administer humidified oxygen. Administer 3 nebulizer treatments of beta-2 agonist 20 to 30 minutes apart or continuously according to orders. Sometimes iprotopamine bromide is added to the nebulizer to increase bronchial dilation. Now, if they're in status asthmaticus, you'll have to obtain an IV access and monitor their ABGs and serum electrolytes. You'll be administering corticosteroids. Always be prepared for emergency intubation. Many times, magnesium sulfate IV will decrease the inflammation and improve pulmonary function and peak flow rate among children who have moderate to severe asthma when treated in the emergency department or pediatric ICU. Heliax can be administered via non-breathing mask to decrease airway resistance and work of breathing. Another complication is respiratory failure, which is persistent hypoxemia related to asthma, which can lead to respiratory failure. And once again, you're going to monitor oxygen levels, acid-base balance, and you'll be prepared for incubation and mechanical ventilation if needed. Whew, that was a lot. This is probably the longest PowerPoint. Respiratory issues in kids is a number one problem. You know, with adults, we worry about MIs and coronary artery disease, and I think cardiac really, is number one. But in children, it's respiratory. More children die of respiratory issues than adults, and more adults die of cardiac issues than children. So I have presented the most important ones. There's still several. When you look at your book, you'll see there are several I skipped over, and some of those were my favorites too. Of course, they all are, right? So take what I've given you and read the book for more information. You are responsible for these topics in your book as well. And be prepared for these on your quiz and tests. This is very important, and this is really pediatrics. Respiratory is pediatrics. None of the other PowerPoints will be this long, and I hope you got something out of it. I'm sorry it was so long. It's important that you know these things. One more thing that I meant to tell you in the beginning that I forgot is the definition of apnea. Apnea is without breathing for 20 seconds or more. I just thought you should know that. Okay, so until we meet again, I'm signing off, and hopefully you guys aren't hating me after this PowerPoint. Good night.